Hello, my name is Roberto Pecoits Filho. I'm a nephrologist, and today I'm going to address to you a potential answer to the question, is it time to revise the limits in CKD anemia? I'll start with my disclosures. I was an investigator in most of the trials in anemia CKD that were recently performed. I was also the national leader and member of the steering committee of a trial called Olympus, and I participated in advisory board and educational activities with these companies involved in the area of anemia treatment. First of all, I'm going to start with a description of the unmet need in CKD anemia. It is very clear that anemia becomes more prevalent as chronic kidney disease progresses. You see here, and focusing on the dark blue bars, you see that the prevalence of patients with hemoglobin levels less than 10, those are the patients that require management of anemia, it increases over time in the progression of chronic kidney disease. And if you look at the stage 5 patients, about a third of patients with a GFR below 15 will require management and potential treatment. Also interesting to note is that as CKD progresses and anemia becomes more prevalent, a higher symptom burden is observed in those patients. Well, this is the way that we currently treat patients with anemia of chronic kidney disease. First of all, we have synthetic erythropoiesis-stimulated agents since the late 90s. And they can be given to patients. We also have several available forms of delivering iron to patients, including intravenous treatments. And unfortunately, in some patients that do not respond to ESAs and iron therapy, we can always transfuse blood. We see that there is no mechanism of action alternatives to those. The treatments that I just described are complex, and they lead to many patients, especially those not on dialysis, untreated. The iron therapy represents a potential harm, sometimes leading to the deposition of iron tissues. And a group of patients are hyper-responsive. And as I said, transfusion could be a common treatment in patients, and can lead to an important complication of the therapy, which is a compromise for a future transplant. So this is the way that therapy evolved over the last 20 years in this area of anemia and CKD. You see, after the discovery and introduction of ESAs into clinical practice, that we gave increasingly doses of erythropoietin to those patients, and as a consequence, we saw a raise in the average hemoglobin for patients with chronic kidney disease. In about 2005, the understanding of the best targets for those agents were defined as a hemoglobin between 11 and 13. But at that point, some of the treatments that try to target a higher level of hemoglobin were published, and they all led to the conclusion that perhaps higher targets were associated with high cardiovascular risk. So at that moment, the FDA released a box warning limiting the upper limit of the hemoglobin that we target for patients. And as a consequence, in the subsequent years, you see here that the target levels of hemoglobin had decreased to the current recommendation of 9 to 11.5 grams per deciliter of hemoglobin. This lower hemoglobin target and the concerns about the use of the therapies led to many patients being transfused as an alternative. And this is a study that was published some years ago looking at the percentage of patients treated with the different ways, different forms of therapy that I described earlier. And first of all, I wanted to highlight the fact that about 39% of patients not on dialysis are not treated. And an impressive number of 25%, they receive transfusions over the course of the follow-up. And this, for dialysis patients, is a similar situation. And you can see here that about 25 to 30% of patients on dialysis receive at least one transfusion over the course of 1 year. So that led to the understanding that there was a need to develop new treatments. And perhaps before developing new treatments, the first thing that happened in the area was the broadened understanding of the mechanisms behind anemia of chronic kidney disease. So this slide represents the way that we understand anemia in CKD currently. So that not only has to do with the deficit of erythropoietin, nor the need for iron therapy, but also understanding that there's another mechanism that is very important, and that has to do with the way that the liver and the kidneys sense hypoxia, and the subsequent release of hypoxia-inducible factor, which when stabilized can lead to the transcription of genes that are very important in promoting the endogenous production of ESAs, but also it could be associated with the reduction in hepcidin and the release of additional iron into the circulation. So once enough erythropoietin is available and iron can be used as a substrate, you can actually see the promotion of the transformation of stem cells into red blood cells in the circulation with the use of the available iron. Interestingly, the treatments that I just described to you, they tackle only the part of the story in terms of mechanism, namely the fourth and the fifth steps here with the use of ESA and IV iron. So the finding that was more than just EPO production and iron in the mechanism of anemia and chronic kidney disease was actually changed with the discovery of these three gentlemen here that you see that studied how cells sense and adapt to oxygen availability. So this led to the Nobel Prize in Physiology and Medicine in 2019, delivered to those investigators, including one of them in the middle here, Peter Ratcliffe, who's a nephrologist. So now let's go from physiology into clinical practice. First, let's review the physiology of the HIF stabilization under normoxid conditions. So with normal concentration of oxygen in the environment, the hypoxia-inducible factor is actually degraded and stabilized. Now, in situations of low oxygen, there is no hydroxylation of the hypoxia-inducible factor, leading to the translocation of the HIF to the nuclei through the translocation and leading to a series of gene transcription. And as you can see here, this generates a coordinated erythropoiesis with the production of endogenous erythropoietin, a reduction in hepcidin levels, leading to the increased production of hemoglobin. So those stabilizers of the hypoxia-inducible factor were developed based on those discoveries. And this is the three main classes or three main drugs in the class of the HIF stabilizers. They are oral drugs, but as you can see here in this table, there are many differences in terms of the dose, the dosing schedule, the half-life, the plasma levels of EPO production, and the metabolism, leading to the need of a series of clinical trials to show if different drugs in this class could lead to treatment of anemia without important side effects. So let's review now the trials, and I'm going to focus on the phase 3 trials of these three drugs in the class. First of all, roxadustat. So this is a phase 3 trial that was developed to test if treating patients with the drug would be efficient and safe in patients not on dialysis. So this trial was designed according to this, what's described in this figure. So patients were randomized, anemic patients were randomized to receive oral roxadustat or placebo and followed for the duration of the trial. The main objective of the study is to look at efficiency in terms of increasing hemoglobin over time. And as you can see here in the figure in the middle, you see a quick and efficient rise in hemoglobin levels in roxadustat treated patients in the red line compared to placebo in blue. And this increasing hemoglobin levels was maintained over the course of the 160 weeks of the trial. Interestingly, as you can see here in the upper part of the slides, even patients who were not iron repleted were actually experienced an increase in hemoglobin levels. And another challenging group of patients with the current therapy is patients who are inflamed, who usually don't respond to iron and erythropoietin. Those inflamed patients, they actually also experience significant increases in hemoglobin levels. So in terms of safety, the roxadustat program actually used a combination or a pooled analysis of these three major clinical trials to look at the safety profile of the drug. And this is actually summarized in this paper recently published, a combination of the studies with a total of almost 2,500 patients on roxadustat and a placebo group. So here you see what we saw, what we described in the previous slide, that the drug was able to generate an increase in hemoglobin levels and a significant reduction in red blood transfusion in that population. And on the right part of the slide here, you can see that the cardiovascular safety was pretty reasonable in the roxadustat group compared to placebo. The drug was also studied in the dialysis population. And here's the results in terms of efficiency and safety of the drug used in dialysis population. So again, the study was used oral roxadustat, but in this case, instead of placebo, for dialysis patients, used as a comparator parenteral erythropoietin alpha. So you see here that there was an increase, a significant increase in hemoglobin levels, which was even higher than what you see for EPO alpha. And on the right part of the slide here, you see no difference in terms of cardiovascular events and all-cause mortality in the two groups. So as a conclusion, the drug was at least as efficacious as EPO alpha and had a similar lower risk of MACE and MACE plus in patients who were new on dialysis. So what are the challenges in the interpretation of those trials? First of all, the trials were presented in a pooled study analysis approach, which has some limitation. There's still some safety imbalances that still need to be addressed, and there are upcoming trials that would be addressing those potential safety issues. The results from real-world trials in countries that have adopted the treatment are ongoing to see if what's seen in clinical trials can also be observed in real-world clinical practice. So let's move from roxadustat to vadadustat and dapradustat, which are the other two drugs in the class. So this is the summary of the results for the non-dialysis phase 3 clinical trials with vadadustat in the clinical trial program called PROTECT. You see here that's similar to what you see in roxadustat. For both patients who were not treated and also patients who were converted into vadadustat from ESA treatments, you see a significant increase in hemoglobin, exactly in the magnitude that we saw for roxadustat. So again, for this other drug in the class, it seems like there is a good efficiency in terms of raising hemoglobin levels in patients not on dialysis. There is a bit of a concern here that you can see here in this study that was recently published at the New England Journal of Medicine in terms of an increase in MACE events in the vadadustat group compared to the comparator darbepoetin alpha, which will need to be addressed in future studies. In terms of dialysis trials for vadadustat, they were captured in the INNOVATE dialysis trial. And you see here that again, the drug was at least as good as erythropoietin or darbepoetin in terms of correcting anemia, leading patients into the target hemoglobin levels. Different from the non-dialysis, for the dialysis population, there were no safety signals in terms of the analysis of the secondary safety endpoints. And finally, this is the first study, phase 3 study of another drug of the class, dapradustat, done in Japanese patients on hemodialysis, showing again efficiency of the drug and no differences in terms of serious adverse events. So I just wanted to summarize with you some of the take-home messages of this presentation. First of all, I told you a story that I think is very interesting on how the improved understanding of mechanisms behind chronic kidney disease anemia led to a potential revolution in the way we manage patients. And this new class of drugs, the hypoxia-inducible factors inhibitors, they have in general demonstrated efficacy. They are an oral alternative to the parenteral treatments that we had available until recently. They were superior to placebo in non-dialysis, in general non-inferior to ESAs. Interestingly, they decreased the iron needs and transfusions, which is an important contribution and an evolution in terms of the standard of care that we have nowadays. And they also effective in patients who usually are not responsive to current therapy, namely the inflamed patients. Thanks very much for your attention.